actually a very interesting session going from the kidney to the lung, and now we'll talk about the coagulation system. And I have one of my declarations is I'm by no means a coagulation expert. I'm kind of tripping into this in the last year and becoming interested. So bear with me, I'm not the expert of coagulation, but I'm a learner, and I'm a little more expert than I was a year ago. So I'm going to show you some data from St. Paul's Hospital, and I'll show you a picture of that here. It's a large tertiary care hospital. 2/3 of our patients come from a local emergency department, and we serve downtown Vancouver. 1/3 of the patients get flown from northern British Columbia over the mountains into Vancouver because we're a tertiary heart, lung, kidney, AIDS, hepatitis, and critical care center. Just so you get a sense of the kind of patients that we get through our ICU when I show you some of our own data. I do consulting work for a number of companies who are developing diagnostics and therapeutics in sepsis and septic shock, so you're aware of that. And so what I'm going to do is talk a bit about some cases. I'm a clinician at heart and a researcher more recently. Some background mechanisms literature, and then show you a couple of recent studies. Because the question, I think, we see less clinically overt DIC when gentlemen on the stage have started their training. We used to see an unusual syndrome where people oozed. They would literally be oozing blood. And we'd see a lot of those patients in the ICU, and we'd investigate them, and many times it was profound DIC. And we simply don't see that as often. So the question is coagulopathy still relevant? Is it a problem? Is it something we should be targeting? And so we've done some studies, and I think it is relevant. I'll show you some data for that. It's a less profound, clinically overt DIC, but there is evidence that there is still a laboratory DIC. And the issue is that progression, is that injury part of the progression to organ dysfunction and increased mortality of sepsis and septic shock? So here's a case. We're going to show you a cohort of over 300 patients in our ICU over about a 1.5 year period, whom we have INR and platelets daily for 7 days, and in whom we then looked at the risk of different organ dysfunctions. So here's one of the cases. I simply went into the database and pulled out a patient whose diagnosis was labeled septic shock. And so this is time at the bottom, and this is the INR. And you can see with this patient with septic shock, the INR went up, and then it recovered. And then if we look at the platelet count was quite low at the beginning, and then it gradually recovered. Here's another patient. This patient was called pneumonia. The INR went up, and then it went down. And the platelet count was a little different. It was pretty good, just around 100, and then it plummeted, and it kind of trickled back up. And you see this throughout the case series. And so it's interesting when you look at pooled data like researchers like me show you that have these nice averages and standard deviations, what you have to think is behind the scenes, in a way, what are your individual patients looking like, because that's what we're taking care of. So my first point is I think you need to understand that it is useful to measure the INR and platelets early and over the first few days, because the patterns that you will see are going to be quite unique. They're a little bit of a fingerprint of how the coagulation system is responding to a septic insult. And one of the ways we do that in research is the SOFA score. And the SOFA score sounds very fancy. It's been used routinely. It's an outcome variable, a baseline variable. And the way we measure the coagulation system is simply the platelet count. That's it. We measure the platelet count, and then we categorize it, and we give points to how profound the thrombocytopenia is. Hematologists are more elegant, and they use a DIC score, but you need to measure not only the platelet count and the INR, you have to measure fibrinogen and D-dimer, and so we tend not to do that routinely and clinically. And so something between that might be something we could be doing clinically, and that would be at least measuring the platelet count and the INR as opposed to the full DIC score, so that you can actually track the coagulation system injury and recovery during the course and resuscitation of septic shock. So with that, I think the background is that coagulation abnormalities are independent predictors of mortality of sepsis. That doesn't prove cause and effect, but it's consistent with a hypothesis that they might be causing that. And we know that from data from Australia and elsewhere that sepsis mortality is decreasing because of, we think, earlier fluid, vasopressor, and antibiotic intervention. And so does that have an effect? Is that why we're seeing less clinically overt DIC, is because we're better resuscitating earlier and more appropriately? And so we did a study, I'll show you in a few minutes, and the bottom line is that we found that using INR and platelets in the last year, 20 to 30% of early sepsis patients have sepsis-associated coagulopathy that is associated with increased mortality, is associated with need for renal replacement therapy and vasopressor. And so it suggests that coagulopathy may still be a rational target for further therapies. This is the data that you've seen suggesting that mortality has decreased progressively in Australia and New Zealand. And this is interesting data people sometimes don't look at or appreciate. In the original Rivers trial, a lot of controversy, and I'm not going to get in that, but given that they used early goal-directed therapy versus usual therapy, there's not an anticoagulant, there's no fresh frozen plasma, there's no warfarin. The early goal-directed therapy group in red had better coagulopathy. I can see the prothrombin time, the D-dimer, the PTT, and the FSP. And you can see over time with significance that the early goal-directed therapy had a blunting of the coagulopathy of sepsis. So again, it suggests that the things that we do for resuscitation, if they're done early, might have a beneficial effect on the coagulation system. Kind of paradoxical, because again, we're not using an anticoagulant or a procoagulant directly. And so let's talk about mechanisms. Experts have published in the New England Journal, for example, causes of bleeding in the ICU. So you can have a low platelet count because of decreased production, a low platelet count because of increased destruction, and then you can have a normal platelet count but have changes in circulating coagulation factors due to liver problems and due to sepsis. So when you have a bleeding patient, you have to have a broad differential diagnosis. And if you have a septic patient, we know that sepsis is a procoagulant phenotype because of this interaction of inflammation and coagulation, wherein inflammation triggers tissue factor, which triggers progression to fibrin deposition, impaired lower platelet count due to platelet destruction, and consumption of circulating platelet factors. In the seminal review that Derek Angus and Tom Vanderpool talked about, they even show it's still a prominent issue in 2013, tissue factor leading to decreased anticoagulation, increased procoagulation, and they're raising this issue, which I'm very interested in, the intersection of anticoagulation with modulators of permeability. So there's a link not only of coagulation with inflammation, there's a link of coagulation with protection of the endothelium against increased permeability. And this is very interesting that I'm learning about now. The Japanese have had a long-standing interest in the relationship of coagulation with histones. Histones mediate tissue injury. They kill endothelial cells in models of trauma. Histone 3 and histone 4 actually mediate many of the things that you see in sepsis and in animal models. Dr. Chuck Esmond showed us in an elegant talk yesterday that an antibody to H4 can ameliorate many of the features of sepsis. So there's this intersection between coagulation and histones, and that thrombomodulin, which we'll talk about in a minute, inhibits some of that histone production and may be part of how it's beneficial. So how often do we see DIC? That's how I started. Well, in the literature, well-done studies recently suggest, in one study, 48% of patients develop DIC when you use DIC evaluation and a DIC score. 32% in another study in 2013, published in 2013. So we're talking 30 to 50%, 50%. And they all showed that the presence of DIC was associated with organ dysfunction and increased mortality. So it suggests that even more recently, we do see sepsis-associated coagulopathy, and it's associated with organ dysfunction and mortality. So even though we're not seeing it clinically as overtly, my supposition and suggestion is it's still there, but it's kind of grumbling under the surface, and you won't see it if you don't look for it. If you don't measure the INR and the platelet count, you won't see it and appreciate it. So why would you have variations, though? I showed you the two different patients who had different patterns of INR, different patterns of platelet count. Even if you look at pneumococcal pneumonia in the same age group, we have different patterns of INR and platelets in this database. So one suggestion, we do a lot of work on genetics, and this is publications in coronary artery disease. Thrombomodulin mutations are associated with an increased risk of coronary artery disease. More relevant, a publication just this year I wrote the editorial with, is that polymorphisms of thrombomodulin and EPCR, as you accumulate more of those polymorphisms in ARDS, Michael Mathey's group, Sapru et al., showed that there's increasing mortality. So variations on EPCR and thrombomodulin increase the risk, or associated with increased mortality, and some biologic plausibility. The genotype of the thrombomodulin modulates the circulating soluble thrombomodulin levels, and that might be an explanation for that association. And that's further shown to modulate organ dysfunction. Remember, more ventilator-free days is good, so you have more ventilator-free days with none versus 1 versus 2 of these polymorphisms. And if you look at the other coagulation, renal, cardiovascular, and CNS-free days, there are these similar trends to more injury and more need for support if you have the polymorphism of interest. Soluble thrombomodulin can also be used and has a high AUC in blue here. It's a predictor of patients to develop severe sepsis. It's a predictor with a strong area under the curve, better than these kidney markers, AUC of 0.77, so it predicts the progression to acute kidney injury. It predicts the mortality of sepsis. And so thrombomodulin mutations, EPCR mutations, circulating thrombomodulin levels, DIC scores, INR and platelets all predict these progressions to bad things. So we were interested in this in our own hospital. This is a submission that we're preparing for publication. And the bottom line is for 2 years, we had these many admissions to our ICU, and we took the patients who had sepsis and in whom we had an INR and platelet count at least for the first 2 days. And what we did was have some entry criteria, and then I don't have the slide, I took it out for brevity, we classified as none, mild, moderate, and severe based on how high the INR was and how low the platelet count was. And what we found is this, that if you look at the platelet criteria, the INR criteria, and then this combo of platelet INR, this progression from the severe, mild, moderate, and none, where the more severe the coagulopathy, using simply the INR and platelet count available clinically, was associated with progressive worsening over 90 days. And that the need for support, if we look at renal replacement therapy, need for ventilation, need for vasopressors, RRT and vasopressor, as you moved across, was greater use both by the INR and the platelet criteria. So it suggests that a simple score using INR platelets can predict severity of the coagulopathy, the need for RRT and vasopressors, and the mortality in a current cohort of patients, not in a trial, but simply all the patients at a simple downtown ICU. So a more elegant approach has been done by colleagues working with AKPA that are studying thrombomodulin and sepsis, and the wonderful lab that I had a privilege to visit of Dr. Farid at Loyola. And this is, again, a cohort of patients with sepsis at baseline in the trial, and it shows two things. First, as you go from mild, moderate to severe, simple SAC defined by INR and platelets, bad things like Pi1, this procoagulant, D-dimer, a marker of coagulation, TAT, F1.2, protein C inhibitor, are progressively higher as you have more severe coagulopathy. And in contrast, fibrinogen falls, protein C antigen falls, and antithrombin falls. So more elegant, broader coagulation biomarker screens, and not shown some of the inflammation markers, are progressively deranged in a cohort at baseline with severe sepsis. So in conclusion, I think sepsis-associated coagulopathy is still common. In our hospital, ICU, which I showed you the picture of, a mixed medical surgical ICU, 25 to 35% of the patients have sepsis-associated coagulopathy, and that is associated with the need for support and mortality. And so I think it's still targeted. You'll probably be aware, or are aware, that this prospective randomized trial of recombinant human thrombomodulant, soluble thrombomodulant in sepsis is ongoing and recruiting at the present. So wonderful to be in Brussels. Thank you for inviting me, Dr. Vincent, and the wonderful associations. I'm learning about coagulopathy, and the many investigators at our own center, and of course the people that are driving this important trial of thrombomodulant, which is actually using INR and platelet to define inclusion.